Good afternoon, everyone, and welcome to the 31st installment of the Stop COVID Deaths webinar series. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center over the National Institutes of Health, University of the Philippines, Manila. It's always a pleasure to be with you all during our regular Friday lunch date. And today, we will be continuing on with an episode for our but it will be on a special topic. So we will have a pause for our in our regular virtual grand rounds. And for today, our topic will be a special edition, which will be the part two of our international conference on medical education in the pandemic, with the special focus on innovation and transformation of medical education. It is the very first international conference on medical education and its innovations in the delivery of medical education content in the Philippines. And as always, during our Friday lunch dates, it's my pleasure and honor to share the hosting duties with my mentor and my partner in crime, the President's Envoy for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie.
Hi, Raymond, and I'd like to greet everyone. Good morning, good afternoon, good evening, wherever you are. We're here to learn. We're here to try to solve some of the problems that we're encountering in the training of medical students. Education around the world is disrupted by COVID-19. But certainly the education of doctors cannot stop. So we are very fortunate to have a number of colleagues from different countries, from the Republic of Korea, from India, and of course from the Philippines. So stay with us. We've got a lot to learn, and I'd like to welcome all the medical students who are watching today. Raymond.
Thank you, Dr. Susie. So as Dr. Susie has mentioned, we have an exciting set of panelists for today, not just the deans of the medical schools from 3 different countries, but we are also looking at the different exciting discussions and presentations from our student reactors. So as mentioned, the COVID-19 pandemic really has caused a disruption in the training of doctors and our future doctors in particular and other healthcare professionals. So medical schools really seek to lay the foundation for the application of all of these knowledge, skills, and attitudes, and most importantly, the ethics in certain, let's say, dilemma-filled situations where decisions are made under high stress. But very, very important still to make those decisions in order to save lives. However, if you make a small miscalculation, it may result in adverse events and may even lead to a mortality. So a lot of our focus and objective really was to put in, highlight all of the experiences and the interactions that we are collecting between and among all of our colleagues, not just in the Philippines, but all across the globe. And our virtual international conference is part of those continuing efforts that was started by the Stop COVID Deaths webinar team. And it's comprised by the University of the Philippines system and also by the Philippine Health Insurance Corporation. So it's really a mixture and a good set of hardworking individuals po, not just from the UP system and PhilHealth, but other partners po that we have, our tech support provided by UP Information Technology and Development Center, ITDC. For those who are watching us in the playback or in the live streaming in YouTube, if you go to the YouTube channel of TVUP, the Internet Television Network of the University of Philippines, you'll be able to see us. And not just an archive of this webinar, but all of our previous 30 episodes for the Stop COVID Deaths webinar series. We also have been receiving consistent and constant support from the UP College of Medicine, UP National Telehealth Center, National Institutes of Health, UP Manila, obviously, and also the premier government tertiary hospital in the country, the Philippine General Hospital. And for those who will be asking, have been asking, continuing to ask with regards to the certificates, those who will be receiving certificates po, they will be receiving, number one, an electronic copy of those certificates. Number two, a copy of the presentations of those speakers for those particular webinars. And number three, you should have spent at least 50% of the webinar duration inside the Zoom webinar for you to be able to be eligible to receive a certificate. So please stay tuned for those who are still waiting to receive certificates from webinar 20 up until webinar 31. Ipapadala lang po namin ito ngayong weekend. And please take note, when you are registering using the registration link, please be very, very careful when whatever you key in or type in, because how your name is spelled will be how it will be reflected in the certificate of attendance. So at this point, I'll call on Dr. Susie again for a very, very quick introduction of our guest speaker who will be welcoming us for this international medical conference.
Okay, thank you very much, Raymond. Okay, let me just see. Okay, thank you very much, Raymond. We are very fortunate to have with us today a one of the pillars of medical education in the Philippines. He is one of the outstanding pediatricians. We've known him. He's been our professor, and we used to study hard under him. And he was Chancellor of the University of the Philippines, Manila, was also Dean of the College of Medicine, and now is the Executive Director of the Association of Philippine Medical Colleges, or APMC. So I'd like to welcome Dr. Arcadio, Dr. Ramon L. Sir, how are you?
Tingnan po kayo.
Okay, I think we need some help. Can't see you, sir.
Meron? Tayo?
Okay,
Go
and
ahead, Dr. Arcadio.
Gaspi there, but Dr. Arcadio, welcome.
Good afternoon. So, I'd like to greet the officers of UP administration, the organizers of this webinar series from the UP Manila and the PHIC, our dear participants, particularly the faculty and students of the Seoul National University and the All Indian Institute of Medical Sciences and the International Federation of Medical Students. I greet also our speakers, the actors, panelists, and our hosts, colleagues, and friends. May I extend our greetings from the Association of Philippine Medical Colleges and the Accreditation Commission on Medical Education of the Philippine Accrediting Association of Schools, Colleges, and Universities, or the PASCO. My brief role is to set the tone of the conference. As a medical teacher, I usually agitate the students. I mean academically agitate the students to keep their interest on the topic at hand. The speakers will talk about innovation and transformation for medical education. The speakers will necessarily mention curriculum concerns, both virtual and in-person, but curriculum concerns should be analyzed after scrutinizing the local health system and the regional health system where we are developing a regional integration. So instead of agitating you, I shall set the tone by mentioning my dissatisfactions. I mean healthy dissatisfaction. Healthy dissatisfaction lead to innovation and transformation and reform of the health system and necessarily the curriculum. The following facts are reflective of the national situation. A lot of Filipinos do not receive health care. 2 of every 3 Filipinos are unattended by a doctor, nurse, or midwife. In many areas, a doctor is seen only when there is a calamity. Too much health care is also very common. When a patient is admitted due to dizziness in a big medical center in Manila, Cebu, or Davao, he's referred to half a dozen specialists, maybe a neurologist, an endocrinologist, an ophthalmologist, and an otorhinolaryngologist, etc. On top of this, we are in an epidemiologic transition where there is a double burden of disease. Infections have not really gone down. The non-communicable diseases are on the rise, while our healthcare system is mainly designed to address infections. This double burden of this double burden uh, taxes the healthcare system. And the first to suffer is the poor, leading to inequities in healthcare access and healthcare outcomes. We think that there are three main causes of this health uh, in the healthcare system. One is the workforce shortage. Next to India, we are the number two exporter of doctors. We are also the number one exporter of nurses. Second is the policy fragmentation. We have about 40 overlapping healthcare programs in the website of the health department. And third is the administrative fragmentation. We work in a decentralized system due to the devolution of healthcare to the barangays, cities, municipalities, provinces, where the health department mainly functions as an advisory body only. There is an urgent need to undertake a healthcare system reform, and we are referring to the primary care system. Primary care is a healthcare system that enables the patient access to healthcare with four important functions. Primary care providers are the first contact. Primary care providers render comprehensive holistic care. Primary care providers are the coordinators for specialized services. They decide if a patient needs a specialist or need admission. And fourth, primary care providers render continuing care after discharge from the hospital. Well, in the academe, the primary care curriculum or, or a training program may be included in the program of community health workers, midwives, nurses, and physicians. Or there may be a primary care curricular package after graduation. Perhaps an outcomes-based curriculum, OBE, with sufficient practices on flexible alternative learning activities or online learning. In the residency program, the lead group are the family physicians, but primary care residency tracks are being developed in pediatrics. We are, for example, at the moment, the PGH Department of Pediatrics is developing a primary care track in pediatrics and a primary care track in internal medicine is also being developed. So the Association of Philippine Medical Colleges is a member of the Coalition for Primary Care, and we are supporting uh, these programs. Of course, the other speakers, the main speakers will talk about innovation and transformation for medical education and will focus on recommended practices on flexible alternative learning activities for related learning experiences for medical schools. I'm sure you will enjoy the topics selected for today's webinar. Thank you very much.
Thank you very much. That was Dr. Ramon Arcadio, the Executive Director of APMC. And thank you for that message. I think that really does set the tone for what we need to talk about. It's my honor and my privilege to also now welcome our guest speaker who will give an opening message. He's a good friend of mine, and I'm deeply honored to introduce him. He is currently the highest ranking Filipino in the World Health Organization, and he's WHO representative to, it's the biggest country, right? I'm going to ask Roderick if it is the biggest country on the planet. And we're fortunate that he has time to be with us. He's been working on um, emergency preparedness and response for over a decade in New Delhi, India. And currently, he's now the country representative of WHO in India. I'd like to welcome Dr. Roderick Ofrin. Roderick, welcome to the webinar.
Thank you, Susie. Thank you, Dr. Mercado, Dr. Francisco Sarmiento. It's my pleasure to be here. Yes, India is the biggest country in the world, and it is the biggest country office for WHO. Just to set that thing.
Right. So, yeah. So, Roderick, before you start your little talk,
Yes.
for you, what is the biggest change that this pandemic is going to make on health systems? Like if we were to go back, like if we're 5 years forward, right, and looking back, what do you think is the biggest change coming out of this pandemic?
Well, I hope a change comes out.
we know.
Let's
We
be
know.
very frank that with every disaster, everyone says that they will change, they'll be better prepared, there will be these systems, there will be these investments, and yet again, here we are. The Philippines just experienced a series of super typhoons. It was a lesson unlearned from previous typhoons. So, a pandemic is not any different. So that is my only hope, that there will be a change for health systems, and that the reinvestment in health becomes a priority for countries. In many governments, it is the least funded ministry. It is usually put in the back burner, treated more as an outcome of development versus a means of development. So my hope is that there will be change. And I think it's advocates who are in this forum that would need to say that and keep at it.
Yeah, we were having this conversation the other night. I was saying one of the things that inspired us to start looking at medical students and our interns, clerks, and those who are in med proper was when Dr. Gap Legaspi said the ones who prevailed upon him to become, to move towards the Philippine General Hospital becoming a referral center for COVID were actually the interns of World War II. And so I hope there are changes in the system, but I think our greater hope is that the doctors who are in training now will be very different and will have values and perspectives that will allow us to move always forward and not uh, backward in our response to disasters, epidemics, pandemics.
Yes, for sure. The responsibility is on us collectively.
Okay, so Roderick, go ahead and give your message.
Thank you. Thank you, Dr. Mercado. Thank you, Dr. Sarmiento, and the organizers of this webinar series, Dr. Arcadio, Dean Charlotte Chiong, Associate Dean Rajiv Kumar, Dean Shinchan Su, all from very prestigious medical education institutions in Asia. My teachers who are in the forum, students, colleagues, good morning. Thank you for this opportunity to speak to you today and open the discussion on this important topic, innovation and transformation of medical students. But firstly, allow me to expand that scope beyond medical students and cast the discourse to the innovation and transformation of all health professions education. To me, it all begins with questioning. A few come to mind when looking at allied medical health education in the context of COVID-19 response, and many are basic. How often did we hear the word pandemic even come up in our lectures? Residency fellowships, where we taught how to manage a patient, a whole ward, a hospital, ourselves in an emergency, an outbreak, a typhoon, or even an earthquake. Considering this pandemic began with a cluster of cases in a hospital, was that scenario even discussed in any of our classes throughout our training? This is not the first pandemic and certainly not the last. And indeed, it is the time to question. What is happening everywhere because of the pandemic is a call to reimagine. If there is anything the pandemic has forced us into as individuals, I'd say it's to pursue insightful questioning. If you haven't done so, it's not too late because the pandemic is not ending soon. As a group of professionals, the pandemic behooves us to do the same. And with its impact on us and around us, I think it is an imperative. It is clear that this is the spirit of this webinar series. And so we all take time to continue the practice of questioning, even in the midst of a global multisectoral crisis, to learn and to find solutions, to question what we know and look back on how we learn, how we were taught or being educated as physicians, nurses, public health practitioners, physiotherapists, pharmacists, etc. Needs a hard relook, a rethink, a rebuild, and that too in a different way. And more appropriately, I think the word is reimagination. It is not enough that we look back at the practice and paradigms we know and improve those, but to move our thoughts outside the sphere of the familiar. Some people call it lateral thinking, disruption, transformative learning. I think by whatever name, we have to have new pedagogic responses to the challenges the pandemic has brought forth, to our competencies, our skills, our mindsets, our hearts as professionals. Some questions to illustrate this point would be, what methodologies would match the content we are learning? Can I learn basic sciences purely online by myself, through videos of teachers, or even procedures through 3D simulations, virtual reality goggles, live feeds? What other disciplines will equip us as practitioners of the future? Information communication technology apps, perhaps, and the skill to interview patients through IC technologies, maybe health anthropology, counseling, or simply effective communication in different media. Maybe what we need is design courses that takes knowledge and practice further. Maybe a degree of doctor of health, not a doctor of medicine, maybe. I think delivering relevant content with the right and new media and measurement of learning and values formation in formats that are beyond us, beyond what we know, requires reimagination. The time to reimagine is now, as there are lives lost every minute and the unknowns of the virus continue to grow, and newer pathogens with pandemic potential are waiting in the wings. It is also a call to realign. That's my second point. One realization the pandemic has highlighted is that none of the systems we work in are prepared or aligned to each other. Dr. Arcadio has already mentioned many. Health systems, transport, supply chains, governance, emergency coordination were stretched quickly and in many ways broken early. It is in that larger context that we need to reimagine education. We are health professionals, not just for one patient, a ward, a hospital, but for a community and a country and the world. Remember that, again, this pandemic began with a few cases in one hospital in a city. We cannot be bereft of context. In fact, we should be changers of context. Again, a few more questions arise on this point. Are schools and universities producing health professionals who will serve the health system? Which one? Which part of the health system? How do the different parts of a health system work together with professionals who are taught in very different incongruent streams? Does having an overarching frame for health professional education solve issues of supply and quality of the health workforce? The disconnect of practitioners with educators and researchers is the key area of response currently in this pandemic, and it's circumstances that push these linkages, not because everything was aligned prior to 2020. Shouldn't there be new regulations for practice for telehealth consults and e-prescriptions? What kind of linkages need to be in place so health education institutions produce professionals for a system that serves the population or a global need? Without realignment of health professional education to the existing health system and other systems, we will continue to experience untapped innovations, disciplines with few practitioners, and sadly, underserved geographical areas and populations, and scarily enough, newer pandemics. Lastly, there is a need to reset. Cliche as it may be, we know that there is opportunity in every crisis. The time to press the reset button is now, and take this crisis as an opportunity. What does the reset entail? To me, it means just a fresh start, a first step. It is a simple series of meetings of and between academicians, researchers, students, residents, ministry officials from various ministries, regulators, researchers, scientists, private sector providers, and their networks to have a frank discussion on what worked, what did not work, and what could be done better. Then from there, work backwards on how we can be better at what we know and what we practice, serving a system that nurtures health professionals and serves people. Every player has a point. We have to approach the reset with humility. Again, a learning from the pandemic that no one country, school, expert, or discipline has the answer to everything. To conclude, health professional education post-pandemic requires us to work together to innovate, transform ourselves and future health professions. In summary, we need to reimagine without boundaries, realign to change the context in which we operate, and to reset with utmost humility. Thank you.
Thank you very much. That was Dr. Roderico Ofrin, who's the WHO representative to India, for asking, I think, some very provocative questions that really sets us into a mode of reflection. And he talked about humility. I think starting from where we really are right now, so that we can collectively find ways not just to survive, but to do better through this pandemic. Thank you very much. Okay, so I'm going to turn over to Raymond, who will start introducing our speakers. So Raymond, please take the floor.
Thank you, Dr. Susie, and thank you for that inspiring and really forward-thinking message from the WHO country representative for India, Dr. Roderico Ofrin. Maraming salamat po. Today, we have three deans who will be giving a presentation on the innovations and essentially how these innovations have contributed to transformations for medical students and also for the delivery of medical education. We will start with the Dean of the UP College of Medicine, Dean Charlotte Chiong, followed by the Associate Dean for Academics, Dr. Rajiv Kumar from the All India Institutes of Medical Sciences. And then finally, we will have Dean Shin Chansu from the Seoul National University College of Medicine. And without further ado, and I know everyone is really excited to learn about the changes and innovations that medical students have experienced and brought also by the leadership by our Dean over the College of Medicine at the University of the Philippines. I'll turn the floor over to Dean Charlotte Chiong. Dean Chiong, go ahead, ma'am.
Hello?
Go ahead, Dean. Yes. Okay.
Yeah,
Okay.
can you hear me
Please.
now?
Yes.
Yes,
Yes. We
first,
can.
thank you, Raymond and Dr. Susie Pineda Mercado for allowing me again to share the experience at the UP College of Medicine and the Philippine General Hospital during the COVID pandemic as a way of discussing medical education, innovation, and transformation during this pandemic. A transformative medical education has always been a goal for the UP College of Medicine since its inception, and this was in 1905. Actually, the college offers two innovative programs. Its Integrated Liberal Arts and Medicine Organ System Integrated Program. It actually accepts 40 direct entrants from high school for its 7-year program and 140 lateral entrants for the 5-year program leading to an MD degree. The other is an 8-year MD PhD program fully funded by the DOST. There are also about 400 graduate students in 27 graduate programs. On the other hand, the Philippine General Hospital, simply referred to as UPPGH or PGH, with the new moniker People Giving Hope, is a tertiary state-owned hospital administered and operated by the University of the Philippines, Manila. It is designated as the National University Hospital, is a national government referral center. Founded in 1907, 2 years after UPCM, it is now the largest training hospital in the country, home to about 575 residents and 311 fellows. And pre-COVID, it actually saw about 600,000 outpatients a year. There's always been a perceived dichotomy between the UP College of Medicine and PGH, the National University Hospital. It's been mentioned that UPCM and PGH are like Siamese twins, joined at the hip and only at the back. They face away from each other geographically and figuratively, and one can only enter each through the back door. The college is viewed as an ivory tower, the academe, while the hospital belongs to the masses. It's a lightning rod for politicians. However, the history of the UP College of Medicine shows, and PGH, shows that the two institutions actually were open during World War II, and they were the only institutions open at that time. During COVID-19 in the Philippines, UPPGH was the only university hospital that was declared a COVID referral center. All elective surgeries were stopped. Several wards were converted to COVID patient wards, and resident trainees were deployed on rotation basis with 1 week on, 2 weeks off for infection control. Nearby hotels serve as quarters for PGH healthcare workers. UPCM classrooms were used as temporary quarters for healthcare workers and also for convalescent plasma donation, as donors actually didn't want to enter the hospital premises. So during COVID, UPCM, for its medical education delivery, actually went to different phases. During the phase 1, when the declaration of a halt to medical education and all other classes were declared in March 12, we had a rapid online shift and ended the second semester by June. This sudden shift to remote learning was actually quite unnerving. And for the first time, the University of the Philippines actually allowed deferred grading for students to be able to submit requirements until May 2021. The phase 2 actually happened when we opened this semester, last September 10. We are fully on remote mode, and we expect to go to phase 3, flexible learning, for the second semester that will start from January 4 and end on May 31, 2021. So the Interagency Task Force, which is a government task force that is multi-agency, actually mandated all the different protocols that should be followed by the public and all institutions nationally, especially in the National Capital Region. And we also followed CHED, as well as the Association of Philippine Medical Colleges, headed by Dr. Dayrit and directed by Dr. Chancellor Ramon Arcadio. So we followed all this, and PGH as a COVID referral center started on March 30, was actually quite a very difficult decision for our PGH director, but the UPCM faculty followed when the decision was made. The courses were redesigned with 2 phases to allow for possible in-person learning, again, by January 2021. We expect to find some of our interns volunteer to come back by November 26. And for the rest, they may be able to come back by January 2021. And this has been authorized by both the IATF, the CHED, as well as the APMC. Now, why is this? Because we have found that the cases of COVID in the Philippines has now started to go down, as you can see on the graph here. And when we look at the admissions of COVID-19 in the hospital, we are seeing that for this month, we are now seeing it's about 1/2 or 1/4 of that of the peak or surge during July and August. So we have now about 100 COVID patients admitted into PGH right now. The testing was ramped up. More than 10,000 testing for healthcare workers were done. And what we realized is that for doctors and nurses, the infection rate is about 1 to 2%. And we are also seeing that the number of COVID positive cases in the non-COVID wards was actually bigger than in the COVID wards. Just that suggested that community transmission is more prevalent. It's fortunate that we embarked on an ambitious digital transformation of UPCM the year before. And this was actually launched during the pandemic in June. We now have a virtual campus providing executive information data, publications, memos, e-library resources, news magazine Inspire with an issue on COVID-19 the last time, that are all online available to everyone, as well as the official Journal of ACTA can be found here. We have free Adobe apps, the 2 learning platforms, Canvas and the UP Manila virtual learning environment are also there. And this provides easy access for all our faculty and students. The coup de grace actually was the legendary batch of UPCM class 2020, which was the last batch to use the BSLR. On their last 4 months, experienced the Taal volcano eruption that then followed by the SARS-CoV-2 pandemic, were able to graduate virtually last July with the theme Hiraya. Even though this was a virtual graduation, it was very meaningful for all of us. They just actually took the physician licensure exam this November. This is the same batch that when APMC declared a moratorium on internship within 24 hours, 130 of them actually volunteered. And this manifests the resiliency of this young manggagamot para sa bayan. Even in June 2019, prior to the UPMASA, when I went there, I was already looking out for virtual interactive human anatomy tables. For the new type of learners that we have now who are actually digital natives, I surmised that leveraging technology to enhance deep learning was important. When the pandemic came, we ramped up efforts and got the 5 groups to donate these 3 such tables. And here you can see Dr. Pio Villacorta, the chairman of the Department of Anatomy, looking at these tables. And you can see here one of our faculty of the department, Dr. Kenny Seng, doing a synchronous lecture using this new technology for our students. We also obtained visualizers, about 4 of them, and more to come, thanks to the donation of the family of Dr. Aileen Apolinario Duwalan, as well as Ini Adralin and Connie Carillo Caprioso. We also embarked on an ambitious CBOL, or Surgical Innovation and Biotechnology Laboratory, the year before COVID came. Actually, we were supposed to get the first 30 million of a 190 million grant last March. But since pandemic came, we had to actually change our plans. And over a weekend, this transformed to a CBOL COVID task force under the leadership of project leader Dr. Edward Wang, supported fully by the DOST and UP Manila. So we can see here the telekamustahan teleportals, so that we allow our patients to talk with their relatives at home to assuage the isolation. We can see here that the telemonitors as well. You can see the sunny pods where actually healthcare workers, before doffing their PPEs, can actually go to the sunny pod and get disinfected for better safety. And you can see here the RX box, which was actually for primary healthcare centers and rural health units, being now deployed as telemonitors at the OB-GYN department for tachometer, for fetal monitoring. That was very much appreciated by the residents, as they can remotely monitor these patients. Research became a very big enterprise during this COVID pandemic. We have about 298 researches now, just COVID related, and of the 360 million funding for this. 300 million actually could be given to projects at the UP College of Medicine, including the WHO trials on treatment as well as vaccines. We even have students, student-led researches of this 298. And you can see here that in the last, the 32nd Faculty Research Forum, Dr. Pipo Bondok actually presented his mobile, locally made ambu bag, which he dedicated to one of our alumni, Dr. Silak Lakyan, who unfortunately died of COVID, while she had no access to a ventilator, being a chief of the district hospital at Pamanao in Sulu. So during this pandemic, partnering with alumni friends and other universities was very crucial. With the UPMF towns, the UP Medical Alumni Foundation, the UP Medical Alumni Society of Davao, the UP Medical Alumni Society of America, the Medical Student Council. We had donors like Smart, Loeb, different foundations, Salometan and Lenatan, Give to Asia Foundation, Mondinisin, Mu Sigma Phi, and Phi Kappa Mu, and Phi Lambda Delta. We had our alumni donate 30 laptops that were actually delivered to our students who were in need of gadgets. We had enrolled about 235 of our students in the AIIMS fundamental course, or Harvard Medical School online platform for pharmacology as well as biochemistry. And this is at no cost to our students, so that they will be better prepared when the semester started. And just after the two typhoons, we had about 47 students from the Unionization Program, or RP, that called for help. And we are now in the process of getting funds for the Pantawid Scholarship Program. We're almost halfway through the mark. So our students are our main stakeholders, actually really needed a lot of support. So we had to partner with Smart and Globe for their pocket Wi-Fi, and as well as their SIM cards preloaded. And we also, of course, had to actually either courier the printed course packs to those who had no access to the internet in their vicinities, as well as digital course packs for the others, and about 30 laptops given to our students, and the excess given to some of our admin staff who remotely work from home, as well as to the different departments for their remote learning delivery to our students. We also improved the faculty capabilities. UP Manila and UP System gave a Canvas workshop for this new learning platform, webinars on blended and remote learning, and a course redesign course. And we at UPCM gave an intensive course on redesign for our faculty, how to plan, how to select their learning resources, design the module, and even design the assessment, as well as writing the course guides and putting it all together. And the feedback on remote teaching and learning actually is that as of about a month after we started the semester, 140 faculty respondents from 20 departments who had multiple roles as lecturers, small group discussion facilitators, course and module coordinators, actually gave us good feedback of good to very good in 95%. 71% of them actually prepared their own course packs, and their main challenges were that of connectivity and internet access. While the students considered connectivity also and access as main issues, with gadgets and laptops that had to be provided by us so that they can carry on with their medical education. But still, we have 3 students in Lanao who still have no electricity more than 3 days after the typhoons, and 47 still needing financial help to be able to cope. So the challenges are there. The approximation of time to task is a challenge for our faculty and our students. We need to improve our asynchronous engagements. The amount of requirements had to be balanced out with what is available in terms of time. We wanted to protect the weekends of our students to improve their mental health. We wanted to guidelines for setting of requirements among our faculty. So what works really is that there has to be clear study guides to study schedules, and the delivery of this remote learning had to be in smaller chunks, we found out, and asynchronous engagement in terms of learning materials and recorded lectures in smaller chunks had to be given. So for the faculty, there was actually a good appreciation among students of the faculty effort in and out of the classes. They understand the challenges that faculty had to grapple with in online learning, but they also appreciated the content expertise of our faculty. So I think this has not been lost in our colleagues internationally. Our own Associate Dean Coralie Doquino was asked to present the best practices for medical education as experienced at the UP College of Medicine. In the inaugural newsletter of the Association of Academic Health Centers, they featured my article on Bayanihan, the spirit of the Filipino comes alive, that summarizes how we grappled with the first wave of this pandemic. And just about 2 days ago, I was asked to talk about managing relationships between medical schools and teaching hospitals. And Dr. Nina Berba gave a lecture on ensuring safety of healthcare workers in PGH. So from this talk that I gave at the HHCI, I'm giving this talk now, and this was really the springboard for my talk. So the UP College of Medicine Clinical Simulation Center is hoped to be able to even enhance the learning of medicine by our students once our medical sciences building is built. And this is thanks to the 300 million donation of the Henry C. Senior Foundation. We're now at the 5th floor. The cement pouring is now ongoing. And it's about every 10 days, we have another floor added up. So we hope to be able to complete this by 2022. We are also working on the Health Simulation Center. This is headed by Dr. J.J. Harmar, and the funding requirement for this is being lodged to Congress with the help of our Chancellor, Menchit Padilla, and our Director, Dr. Gapri Gaspi. So clearly, universities, medical schools should prove their civic value to society during this COVID-19 and also beyond. In the last graduation that was held in person, you see here Director Gapri Gaspi, who is actually a neurosurgeon. And really the secret for that very smooth relationship is the fact that we have been working together since 1993 on skull-based surgery, I being a uro-otologist skull-based surgeon. And I think that the leadership has very important roles in being able to manage the problems and challenges during the pandemic. It's true that we cannot only look at the hospital, but we have to look at the bigger picture. And the bigger picture is that the hospital is the last station. And that if we are going to really change for the better and go to the next normal, it has to be with the realization that healthcare reform should be done now, that we should be able to engage the whole of society and the whole of government and emphasize that it's important that healthcare is considered as a jump board for overall development of the country. Para kay Juan at para kay Juana, importante po na tayo ay magsikap, mapabuti pa ang pag-aaral ng ating mga manggagamot. I can imagine that those who will be graduating from our schools today will be at the peak of their careers about 20 to 30 years down the road, when we ourselves now listening will need this care. And therefore, it has to be on a personal basis that we invest in their medical education. I am sure that leaders managing the academies, the hospitals that serve missions of being able to work for society should consider that in these extraordinary times that we are in, we have to exert our best effort. Because after all, this COVID-19 is just a surreal interlude that too shall pass. I'd like to thank you again for listening. Over to you, Dr. Susie and Dr. Raymond.
Thank you very much. That was Dean Charlotte Chiong of the UP College of Medicine. And we're looking forward to having you, Dean, at the panel discussion. From the Philippines, we're going to move to India. And it is my honor to introduce the Associate Dean for Academics of All India Institute of Medical Sciences, Dr. Rajiv Kumar. Dr. Kumar, welcome to the webinar, and please proceed with your presentation.
Good morning. Thank you very much for this invitation, and it's a pleasure and a privilege to have been invited to be a part of this session and to present at it. I'm hoping you can see my slides now. Is that?
Yes, we can. There you go.
Okay, perfect. Thank you very much. It was a pleasure listening to the speakers before me, in particular, Dean Chiong and the experience at UPCM and PGH. There were times when I thought that if I could simply remove the alphabets UPCM, PGH, and replace them with AIIMS, the message would practically be the same. Our experience has been virtually the same that she has shared. And some of the timelines that she has talked about setting up the skills labs and interaction with students were actually virtually the same. So it's very interesting how, having had no contact whatsoever, our experiences around the world tend to often be very similar. I'll begin again with a brief introduction of what this institution is, so that puts into perspective our role in terms of how we interact with our community and the country. The All India Institute of Medical Sciences is an autonomous institution established by the Government of India in 1956. What this basically means is that we make our own rules, we award our own degrees, and we are not obliged to follow any central pattern of instruction or awarding degrees, which gives us a lot of freedom. We can pretty much define our own curriculum, define our own courses, define our own degrees, and they are valid degrees recognized all over the country and across the world. So that not only gives us freedom to do what we want to do, it also puts a lot of onus on us to innovate. The principal reason why we were created was that we were supposed to innovate and design new techniques of education and imparting training. So that builds a little bit of a pressure upon us to do the right thing, because we are being watched by a lot of people around the country. Over the last 60 odd years of our existence, we have been perpetually ranked the #1 institution in this country in all 3 areas which concern medical education and medical treatment. So we are ranked the #1 medical school in the country. We have the highest research output among all the medical institutions in this country. And we're also ranked the best hospital in the country. So that also puts a little bit of an extra pressure on us to do the right thing, because we're being watched and we are expected to lead the country. The total number of inpatient beds that we have in the main hospital plus the satellite hospitals is greater than 2,500. And virtually everything that we do for the students or for the patients is free. So you could come in and get a robotic radical surgery. I'm a urologist, so you can come in and get to do a robotic radical surgery for free. So that's the institution that we are talking about here. Again, a brief description of our academic courses. We have about 50 teaching departments and centers, about 1,000 faculty, and at any given point of time, we have about 2,800 or thereabouts students, residents, and PhD scholars. As of this year, we will take in about 130 undergraduate students to the medical program. And there are, well, this is last year's data, there were about 300,000 applicants for the 100, and last year we only had about 107 seats. So about 300,000 applicants for about the 100 odd undergraduate training program seats that we had. And of course, we impart training in medicine and paramedical disciplines all across the board for medicine. In terms of research publications, we produce the largest number of research manuscripts in the country among medical institutions, also the largest number of high impact factor publications across the country. We have collaborations all across the world with some of the topmost universities primarily for research. There's very little student exchange, but this is primarily research. And in terms of raw numbers, again, we see over 3 million outpatients per year. We admit over 200,000 patients every year, and we perform over 200,000 surgeries every year. So it's obviously a large, crowded hospital. I haven't put up pictures to show you those crowds. I'm sure you quite understand what that would be all about. And of course, it's all for free for the patient and for the student. So of course, it's not free in general. The government funds us, which is why we can do it for free. But then for the end user, which is the student and the patient, it's undoubtedly a huge boon. So now let's look a little bit at what we did over the last 6 to 8 months when COVID first struck us in March. When we first came to know of COVID and its impact, the nation went into a complete lockdown for about 7 weeks, which means absolutely complete shutdown. And exactly as was described for UPCM, all classes ceased completely right in the beginning. We were the first hospital to be converted completely into a COVID care, research, and policy development institution. So all routine admissions, all routine surgeries were stopped. We have a large trauma center right next door to our main hospital. We emptied out our trauma center. It was a full hospital with numerous patients on ventilation and sick patients. They were immediately moved to the main hospital, while the primary trauma center itself, with about 280 beds, was converted into a completely COVID facility with its ICUs, operation theaters. We also have an additional satellite center about 50 kilometers from here, which was primarily a cancer center, which was commissioned just last year. That also was converted into a COVID care center with about 600 beds, 700 approximate beds. And we also, at the same time, when we started doing all this, initiated an intramural research grant set up, where about 40 research grants were immediately given out with rapid ethics reviews and commissions approvals for both money and for ethics for in-house researchers to begin COVID research projects. And of course, we contributed to various national policy decision-making bodies across the country. All routine activities completely ceased except for cancer care and emergency care. So if somebody was sick and needed urgent care, which would lead to deterioration of his condition, that of course continued to be provided. The emergency services continued to be provided, and cancer care continued to be provided. And most of our residents and students were redeployed right in the beginning of March or early April itself. In terms of undergraduate education, and I'm going to focus primarily on undergraduate medical education, which is basically the MBBS degree. The first casualty was the intake of the new students. So our new batch typically would come in August, and the preparations would start somewhere in July, in actually April, May, June. And that had to be deferred. So our first year undergraduate students will only come in next month. So the admissions were delayed, and it's going to be December instead of August, as it usually is. The other major change was the need for social distancing. We are planning to start physical classes as well. It may be December, may be deferred to January, but we do have to make provision for physical classes, and our existing lecture theaters do not have provision for social distancing. So the first change that we made there, and for the existing students, it's of course gone online, but for the batches that are going to start with physical classes, the first change was that we've had to requisition our auditorium, which has about 1,000 seats for the undergraduates. So for if we have about 130 first year students, we're going to put them into an auditorium and with adequate social distancing of about 3 to 4 seats between each student. So that's the first change that happened, that the auditorium has now been requisitioned for the entire year next year for the first year undergraduate students. And of course, there's going to be a change in how we deliver education, which has to be delivered hands-on. So what used to be delivered in relatively larger batches of students going to the anatomy, physiology laboratories, or the dissection halls will now become small batches, and multiple faculty will be involved in teaching. So if there was one faculty for 6 students around one table originally, it will probably now be one faculty for 3 students around one table. So changes at that level are being planned. This is for the first year that I'm talking about, assuming that we're able to do physical classes beginning either December or January. So everything becomes small batches with greater spaces. For the existing students, which is year 2 onwards, there of course has to be a shift to online teaching. And again, very similar to what I heard about UPCM, we launched our online education portal just about a year ago. We call this portal SARL, which is Student Advanced Resources and Learning Platform. This incidentally was launched in 2019, and the schedule for the existing students was completely redrawn. For example, if they were engaged for about 8 hours a day currently, there is no way we can give them a screen time of 8 hours every day. So the entire schedule for the existing students was changed so as to minimize continuous online screen time. So if there was something that needed to be seen, that had to be decreased, whereas there was something that was to be discussed, that was interspersed with what was to be seen. And we relied a lot on the flipped classroom model. So for example, these are screenshots from my login as a teacher on the SARL platform. I have a role for teaching undergraduate students. I do didactic lectures, I do hands-on training, and I also do training on what's called the foundation course. So I uploaded, so if you look at this part of the screen, which includes my lectures that I was supposed to deliver to the batch of 2017 and to the batch of 2016, I've created videos of my talks, and I've uploaded those videos of my talks. I've uploaded my slides depending on which lecture can be handled in which manner. We also train all our students on COVID-19 management, and those modules are also online. as are our foundation course on research methodology, writing, ethics, on speaking, presentation skills. So all that has also gone online with slides and PowerPoint presentations. And of course, our skills training, which till now was entirely physical, now has modules both for residents and undergraduates, all accessible online through multimedia presentations. So although this beginning was made in 2019, COVID really gave us the push to put it all online immediately. In terms of clinical training, we of course cannot have students coming into areas which might have COVID exposure, and the number of patients of routine conditions are no longer there in the wards. Therefore, all clinical departments have created simulated cases and are now discussing clinical scenarios through simulated courses online. Skills training has gone virtual, and for whatever physical training we're able to provide, because some students are still able to come into the physical training sessions, are now able to come in for small group skills training. These pictures are of course from the pre-COVID era. I did not take pictures during the COVID era yet. But these were our skills labs that were very densely used in the pre-COVID era, but obviously we can't do this anymore. So we now have maybe one student at one table, one preceptor, one faculty in a room with just about 6 or 8 students, and they learn skills training in smaller groups now. When we talk about assessments, all assessments moved online. Some assessments were dropped, and those which were intermediary to the whole course were dropped, whereas of course the final graduatings or the end year semester assessments are still being held. But all of these are now being held through simulations, and of course, no physical presence of students. So we're using objectively structured clinical examinations, we're using simulated cases, and we're using online from home questions which students can address at home. We of course needed to train our students and our residents for COVID management because a lot of them have been deployed in COVID areas. So training them on infection control was our primary focus. Donning, doffing, standard management protocols for undergraduate students. This was done for everyone. All level of healthcare workers were mandated to go through infection control protocols, both online, then interactive online. So online was both asynchronous and synchronous, followed by some degree of physical question answers in large halls with physical spacing. Residents were also trained in ICU care, ventilatory settings, because they were now part of multi-specialty teams posted within the COVID area. So you would have an anesthetist, a critical care person, a surgeon, a physician, somebody from anatomy, somebody from physiology, teams which consisted of people of all kinds of specialties, and everybody had to have some degree of basic training, which was provided both online on our Surreal platform and offline reinforcements. In addition, we started rapid in-house reviews of literature because literature was coming in by the tons, and we needed to sift through that literature and provide concise summaries, both to our physicians and to our students. So we started rapid literature reviews, which were posted on our websites. So this is this is our website on COVID care, where we've got numerous modules on education, literature review, training, best practices, guidelines, all available at one place for not just for our residents and our trainees, it's available for everybody across the country. We also had a responsibility to educate and train and policy development across the nation. And therefore, we've done multiple actions, which include national grand rounds, which are training programs, which we air every week, where we discuss cases, take questions, live questions from physicians, and answer those. They're answered by a panel of experts from across the country and abroad. We do a Center of Excellence program where we train other institutions across the country in management of patients. We do what's called an EICU, where once or twice a week, we invite people treating COVID patients, doctors treating COVID patients, for a live interaction with physicians so they can ask specific patient-related questions. This is my patient, this is his problem, how do I handle him? We do this twice a week for all over the country. And then, of course, we lead a mentorship program to ramp up testing. So we've been able to establish over 1,000 laboratories for testing using RT-PCR across the country, and we've been anchoring that mentorship program. We, of course, also have a YouTube channel where every educational material that we produce is available free, and some of these have had over 100,000 views already. So finally, what is the way ahead? The way ahead is that we will all need to restructure our education program. COVID's not going away, and more might well come. So we need to rethink. how much of it really needs physical interaction, how much can be done hybrid, and what are the possibilities of using small group activities. However, medicine, to my mind and to most of us, is not something that can be done remote or done online. There is clearly something that can be done remotely and something that can be done online, but medicine requires a clear human interaction for students to understand empathy, need, and be able to give that to their patients. No amount of simulated patients, no amount of hybrid education can cover that. And therefore, we will have to find a way to bring our patients back into contact with our patients at some level. And that's the challenge which we are hoping to address over the next year when we are allowed to admit more patients and have some degree of physical interactions. Thank you once again for the invitation to be here as a part of this program, and I'm grateful for the opportunity. Thank you.
Thank you very much. That was Dr. Rajiv Kumar of the All India Institute of Medical Sciences. Thank you for that presentation. From India, we are now moving to the Republic of Korea, and it's my honor to introduce Dr. Shin Chan-soo, the Dean of the College of Medicine of Seoul National University. Welcome to the webinar, Dr. Shin. Kindly proceed with your presentation.
Thank you, Dr. Arcadio and Dean Chiong and Dean Kumar and Dr. Ofrin. My name is Chan-soo Shin. I'm an endocrinologist as a specialty and currently serving as the Dean of SNU College of Medicine. First of all, I'd like to express my sincere thanks to the organizing committee for inviting me to give this talk. Today, I'm going to talk about what we have done during the unprecedented crisis by the outbreak of COVID-19. Okay. As of yesterday, there have been more than 55 million confirmed cases of COVID-19 around the world, including 1.3 million deaths reported by WHO. The Republic of Korea has reported more than 29,000. As of we exceed 30,000 now, and almost 500 total deaths according to WHO. This graph shows the changing trend of confirmed cases per day in South Korea. After reaching a peak on March 28th, here, the number of cases has decreased steadily, and there are a couple of periods with increased cases. And as you can see here, we are experiencing recent surge of new cases. It seems that it is getting hard to trace all the cases as community infection became widespread. The age standardized incidence rate in Korea is very low. However, compared to other countries, as well as the age standardized mortality rate here, which is also very low. In April 1st, SNU Medicine has organized COVID-19 scientific committee to provide statistics and scientific updates on COVID-19, which can be accessed through the SNU Medicine website. The scientific committee provides weekly updates on COVID-19 statistics of Korea, as shown here, in a more dynamic and graphical way. The epidemiology section provides updates on the global statistics. And the clinical information, including the severity profile and expert opinions on diagnostics, vaccines, therapeutics, are regularly updated. In addition, the committee publishes bi-monthly newsletters that covers expert opinions in many areas of interest. The committee also hosts webinars inviting speakers from around the world to share their COVID-19 experiences with Korean audience. Next, I will talk about the effect of COVID-19 on teaching in our medical school. As you can see from the graph, after the first case reported in January 20, the number of new COVID-19 cases increased rapidly in February. Korean government declared the highest level of alert on February 20 and initiated infection control measures, including physical distancing and contact tracing. We suspended all classes on February 24th. Immediately after that, we started preparing online lectures, and the online class started on March 16th, which was 3 weeks after the suspension. Online lectures were created in 2 ways. Professors record their lectures in a studio, or they simply add their voices on their lecture slides and then upload it into the SNU e-teaching and learning website. Meanwhile, some professors are interacting with the students using Zoom platform. Although the lectures were given online, all the exams were done offline. We divided the whole class, 150 students, into 4 classes and made sure there was enough space between the students. Travel histories and respiratory symptoms were checked, and body temperature was taken in every student. As the number of new cases were gradually reduced, we resumed lab classes and clinical rotations in May. To minimize the risk of cross-infection between the students, we divide them into 3 classes while doing cadaver dissection, as shown here, and also in other lab classes. Now, you might be wondering how satisfied students and professors were on the online learning and teaching. As you can see here, interestingly, over 60% of the students prefer online learning. On the contrary, professors prefer traditional lectures. Students prefer the online lecture because they can watch lectures whenever and wherever they want, and repeatedly until they fully understand the lecture. Next question is the performance of the student compared to traditional lecture, which was in year 2019. As you can see here, while the performance, the test score of biochemistry was similar between 2019 and 2020, the score of anatomy class was lower compared with that in year 2019. Our interpretation for this low performance in anatomy is due to the reduced opportunities in cadaver dissection and other lab classes, which negatively affected students' performance. The COVID-19 wasn't able to stop us from collaborating with our global partners. Offline networking and travel is difficult, but international cooperation has become even more essential in fighting with the coronavirus. So we hosted a webinar on medical education during COVID-19 in July to share experience and exchange knowledge and ideas. 8 Asian medical institutions from 6 countries with whom we have been working closely in the student exchange participated in the webinar, along with Professor Roger Wang from the University of British Columbia as a plenary speaker. We strive to continuously stay connected with our partners through various platforms. As we have seen, COVID-19 forced us to change the education environment. Many creative changes are inevitable, and returning to pre-COVID-19 area is very unlikely. Faculties previously resistant to technology-enhanced teaching are now doing well to meet the needs of students who value adaptive and self-directed study. Augmented intelligence and machine learning will support this model by achieving the goal of more tailored outcome-based education. I'm sure that the additional innovations are absolutely required in areas such as anatomy, problem-based learning, clinical skills education, assessment, and mentorship or career advising. Okay. Now I will briefly talk about clinical innovation in terms of COVID-19 response in our institution. As has been already known in many news media, Korea has come up with an innovative way of testing the coronavirus, and it was inspired by the drive-through counters of McDonald's or Starbucks, which is for sure a safe and efficient way of mass screening. We have also implemented walk-through system. Here we place the healthcare worker inside the booth while the patient stands outside to be tested. This speeds up the process since the booth inside does not need to be disinfected between patients. When the first news on the coronavirus infection in Wuhan was reported, CGEN, one of the Korean biotech company, stopped all other work and ordered to focus entirely on producing diagnostic kit for COVID-19. Then, after the very first case was confirmed in Korea, Korean CDC reviewed the testing kit and approved the test kit for use in just 2 weeks. Such go-ahead typically takes at least 6 months. The availability of many testing kits, along with the government's rapid response to the massive testing and other measures, has helped us contain the spread of COVID-19. In addition, extensive contact tracing has contributed to successful containment of the spread without deployment of city lockdown. However, such measures include reviewing numerous surveillance camera footage and mobile phone and credit card transactions, which have raised concerns on the human rights as too much information have been collected and released. Seoul Regional University Hospital, the main teaching hospital of SNU, has operated so-called Living and Treatment Center in Mungyong area, which is a rural city about 170 kilometers away from the hospital. Here, COVID-19 patients with mild symptoms are admitted under medical monitoring to avoid massive influx of patients to the main hospital in order not to occupy the limited number of negative pressure beds. Patients live there and perform self-checkup under constant monitoring by medical staff at SNUH, Central Monitoring Center. Living and Treatment Center has implemented advanced information technology system. Every patient is provided with a vital sign measuring device and mobile phone with our monitoring apps. All patients check their symptoms using a mobile questionnaire. body temperature, blood pressure, and oxygen saturation data were recorded and transmitted to the Central Monitoring Center. If there is any sign of worsening, the patient is then transferred to a tertiary medical center for further care. Some patients with anxiety can also consult psychiatric consultation via video conference. COVID-19 has brought us unprecedented abrupt disruptions in our life that have caused us physical and psychological health problems, which could be a big threat to our life. There are some hopes on vaccines and treatment for the COVID-19 now, but it is not guaranteed that we could fully depend on them to end the long battle against COVID-19. Considering these uncertainties, people generally seem to agree that we may have to embrace the reality, living together with the COVID-19, the so-called new normal, which will change our life to a great degree. Even though COVID-19 has forced us to change our way of life against our will in many ways, we could focus on positive changes and utilize them also as opportunities. One of the positive aspects of this is that it will bring a paradigm shift in many fields of our life and accelerate innovation in those fields, such as remote working, distance learning, digital banking, online delivery, and also telemedicine. Thank you very much.
Okay, thank you so much, Dean Shin. And then we'll move on very, very quickly to our set of student reactors. So it will not just be the deans or the heads of the medical schools which we will have today, but also reactions from three different student reactors. First up will be Mr. Ji Hyun Kim from Seoul National University College of Medicine, followed by Terence Lapeñas, who is the regional chairperson to the Asian Medical Students Association International from AMSA, Philippines. And then finally, we have Ferdinand Nico Bautista, who is the National Medical Interns Chapter Chair from the Association of Philippine Medical Colleges Student Network. So we'll start with the student from Seoul National University, Ji Hyun Kim.
Oh, okay. Hello.
Yes, we can hear you loud and clear. Go ahead with your talk.
Okay, thank you. So, hello, I'm Jihan Kim, and the president of Student Council at Seoul National University College of Medicine. The students at SNU, Seoul National University College of Medicine, are right now finishing our second semester, and we have about a month or two left. When COVID-19 hit Korea, the school made a very swift decision to actually kind of close the school and stop all the schedules for all sorts of classes. And we were very stunned. I can still remember that it was Sunday afternoon. Yes. So I have one for my mic and another for my video due to audio issues. And I can still remember that it was Sunday afternoon, and we were supposed to go to school and take classes tomorrow morning. But I got a call from the school that we are ceasing all the classes until we have some assurance that students are safe and have some guidelines pertaining to COVID-19. And of course, we were shocked, but now we see that school was certainly right to make somewhat drastic decision, because due to the characteristic of College of Medicine, where a class of students almost always take the same classes and be in one place all together, if any one of us were to be infected, then there is a very high chance that all of us might get infected. So so after the preparation of guidelines, we were able to resume taking classes. It was online. it was very new to us and probably very new to professors as well. So there were some trials and errors at first, such as audio problems or video upload problems, but soon we were able to take the lessons of very high quality. And then after the preparations of equipments, such as masks or hand sanitizers, students at third and fourth year were also able to participate in clinical rotations. And also all the students were able to take the tests upon strict COVID-19 guidelines. As the dean said, guidelines such as 2-meter distance per student and equipping the masks and divisions of classes to have minimum number of students per room were applied. So we were also able to come to school and take the tests or take clinical rotations. So that has been the case of our school until today. And in the end, students are very satisfied with such guidelines and such online classes. Well, I guess the best part of online classes is, of course, we can take the classes very safely. There's no need for contact, nor the need to actually get out of your home to face COVID-19. And another great part of the online classes is, which the dean also said, that we can take the classes very safely. I mean that we can always take the class again if you missed the part which the professor said, and also take the class maybe a bit later than the scheduled time if you happen to have some urgent issues. Audio issues or video upload issues were some of the problems that we faced at the beginning of online classes, but such problems were solved quite quickly. So there are right now no technical problems. So all in all, the students at Seoul National University College of Medicine are quite satisfied with the academic environment, which provides both safety and high quality lessons and practice. Thank you.
Thank you, Ji and Kim, for the really spontaneous but wonderful reaction. We'll move on to Terence for his reaction
Hello,
from AIIMS
okay,
International.
good afternoon. I will be sharing my screen.
Go ahead, Terence.
Okay, thank you. Okay. Again, so good afternoon, everyone. I am Terence M. Lapeñas from the UST Faculty of Medicine and Surgery and the Regional Chairperson to AMSA International of AMSA Philippines. And there, so to give a short preview on what our routine was pre-pandemic, it basically consists of the following activities. So we have our 7 a.m. to 5 p.m. Monday to Fridays on-site classes. We have our live discussions, small group discussions, laboratory, bedside teachings and hospital rounds, and a lot of pre and post tests, and also including reportings. So we all know that mid-March of this year, the pandemic forced the Philippines to stop face-to-face learning activities and abruptly shift to online curriculum through various forms of remote or online learning. So we were actually halfway into our second semester that time. So it is important to note that there are no studies that describe the utilization of and capacity of for online teaching in the Philippine medical schools. So the pandemic has disrupted medical education worldwide, and the Philippines is no exception to that. So to give you a background, my organization, AMSA Philippines, is affiliated to two international organizations. One is AMSA International, and the other is the International Federation of Medical Students Associations, or the IFMSA. So last April 24, they had this international survey to track medical education during the pandemic. And out of 100 countries that they have affiliates with, 93 suspended their education, wherein 2,584 medical schools suspended. So that's around 94%. So when the pandemic started up until now having our full online classes, our activities are divided into two: synchronous and asynchronous activities. So for synchronous, we have live lectures, flipped classrooms, reporting, quizzes and exams, workshops, and interactive sessions like games. For asynchronous, it basically consists of different outputs. Although we have recorded lectures that we can view at our own pace, we have video demos to submit, written outputs, and capstone activities like concept map, infographics, and even advocacy videos. Then I actually participated in a national survey conducted by a UP professor where they identified the barriers to online learning by medical students here in the Philippines. And months after, I was able to take a look at its published paper online. So they were able to identify 5 major barriers. So first, it was the technological aspect, which pertains to our devices used for online. Of course, not everyone has laptops or iPad, and stable internet connectivity are the most common issues. Next is the individual, which involve students' learning styles and mental health in different learning environment. And next is the domestic or the which pertains to family issues or concerns that we have to perform responsibilities at home, or even lack of physical or conducive space for learning. Next is the institutional or which revolve wait, institutional which revolve around the administration, the school resources, or the medical curriculum. It also stems out of the poor communication skills between the educator and the students. Lastly are the community barriers, which involves the socio-political issues or the lockdown restrictions. So Philippines has documented more than 410,000 confirmed cases of COVID-19 as of yesterday. So face-to-face classes and hospital rotations are not expected to resume soon, or not for the second semester of this academic year at least. So the real question is still, how should medical schools prepare for the future? So seeing how COVID-19 affected medical schools, both the administration and the students are affected in carrying out their desired performance. So this is a call for institutions to come up with standard protocols and for medical schools to better equip themselves with procedures that can be operational no matter what the crisis may be. But we have to take note that the Commission on Higher Education, or CHED, the key agency mandated to promote quality higher education, has no guidelines nor protocols on the Doctor of Medicine program for the minimum set standards and resource requirements for remote or online learning. So this unprecedented situation presents an opportunity to critically examine the state of our medical education nationwide and to systematically evaluate the effectiveness of online curriculum in a developing country and formulate contingency plans for similar circumstances in the future. And so we believe that there is a need for a needs assessment survey among medical students. We need to identify those with limited access to technological resources or even the basic needs. We need to ensure open communication channels among administrators, educators, and students through online town hall meetings. Like in our medical school, we have what we call Thursdays with the Dean. So at least once a month, there is the Dean arranges a town hall meeting for us to voice out or to bring up our concerns or problems encountered in our medical education through online learning. Guidelines and expectations must also be clear. So we have to, with provisions for improvement or worsening of the pandemic situation. We also need to implement a primarily asynchronous mode of content delivery for us to ensure that students can review or view it at our own pace, and of course with minimal and technical data requirements, of course that those that require only smartphone compatible. So to sustain the online curriculum, policies in a broad array of concerns can be created. So we can invest in technical support or to support that and train faculty on content creation, management, and delivery, similar to what I saw with UPCM. what Dr. Chiong has presented a while ago. We also need to avoid cognitive overload. As with classroom teaching, we need to ensure that the assessment measures are aligned with the desired learning outcomes. So we need to extend leniency to students, develop mental awareness programs, and provide proactive psychosocial support for the students. We need to also create opportunities for meaningful interaction with peers and mentors, and to give discounts on tuition and offer scholarships to cushion the pandemic's economic impact, and if possible, advocate for greater subsidies from the government. And on a more positive outlook, to develop bridging programs so we can prepare for gradual return to clinical activities. And moreover, we should also push for first aid and emergency triage assessment and treatment training. So a curriculum regarding triage assessment prepares medical students in times of national crisis to be deployed whenever they are needed. So this could help address the issue of human resources for health during a crisis, as more students are trained and knowledgeable enough to even just assist in the front lines. So lastly is to connect with the student organizations that embody a greater network of voices from the students. Because really, there is a great untapped potentials in these organizations. Like for example, in AMSA Philippines, we have our Standing Committee on Medical Education, that is exposed to global view for medical education and a lot of capacity buildings that hook on pushing for advancements and student input to the school curriculum. So by implementing student-centered interventions, medical schools and educators play a significant role in addressing these challenges during the COVID-19 pandemic and beyond. So I think that is my last slide. Thank you for inviting me again, Doc Sarmiento.
Thank you, Terence, for the take from AMSA Philippines. And then finally, we have the National Medical Interns Chapter Chair, Nico Bautista.
Hi guys, good afternoon everyone. So I am Nico Bautista, the current chair of the newly established National Medical Interns Chapter of the Association of Philippine Medical Colleges Student Network and the president of the Department of Health Philippine Centers for Specialized Healthcare Interns Council. Now, undoubtedly, the COVID-19 pandemic has made a great impact on us all, especially for the students. We were caught off guard by how sudden all of these changes were brought to our table. Some may even say that though we knew that this was coming, there was no gradual ease into this big shift. For some, this change appeared to be better for them, and they were able to do multiple tasks at the same time and forge a better relationship with their families since they are spending more time with them. But being part of the National Organization for Medical Students, we have received multiple concerns regarding how the students are not able to cope with this big change. Students had problems with internet connections, power interruptions, compartmentalization of life spheres, and mental health problems. As medical professionals, we know that these things cannot be shrugged off. The environment and the preparedness of the learner play a big role in achieving the goals of education. We laud the efforts of various academic institutions for continuing with its goals of forwarding medical education and trying to make sure that we, the students, get to continue with our studies despite the pandemic. We were able to somehow adjust and implement online programs that still simulates our thinking, though we are miles apart. We have various institutions who incorporated online platforms, virtual small group discussions, and even telehealth simulations that really present itself as advantageous to our medical learners. This is the new front of medical education that we have to face, but we all know that this is still lacking. As mentioned by Dr. Kumar earlier, the practice of medicine is not limited to theories, and our teachers are not limited to our professors. We are not limited. We should not contain ourselves to the idea of cure, but also look at the field of health as a whole. As medical academics, we acknowledge that these problems are not just rooted from the spread of COVID-19, but also because of the system that we currently have. We have been too caught up with standards and ratings that sometimes we fail to recognize the wholeness of the person. For education to be effective, we must not only focus on what topics or modules are instructed, but also how these are delivered. The missions and visions of our pristine medical institutions are not ornamental. It requires action. Just like what Chancellor Nemenzo mentioned in his recent statement, the calls of students and professors to end the semester, though very radical and straightforward, should not be construed as abandonment of one's education, but a legitimate expression of their commitment to teaching and learning. I mean, we feel ambivalent with all the technologies that were presented earlier by our prestigious speakers. It inspires us to learn more and do more with the innovations shown to us, but it also saddens us to think that not all of the medical students have the same opportunities as the others. Highlighting our Filipino value of pakikiisa, we also acknowledge that all students should be given an equal opportunity to continue with their education despite our situation, not only with the pandemic affecting our country, but also with the recent natural calamities that struck our nation. There are a lot of students who are at risk of failing to continue with their studies. It is a call for us to take a break, reevaluate our policies, and create an inclusive environment for both teachers and learners. Mahirap sumabak sa gera nang hindi ka handa at nag-iisa. Just like what Dr. Orphin mentioned earlier, we hope that there is a change that will come out from this situation. Outbreaks and natural calamities have been happening multiple times in our country, and patterns have been set. And yet, our efforts seem to be inadequate. We need to take this crisis as an opportunity for us to incorporate the study of different systems, management, and policies that does not only focus on on one individual's disease process, but to a community's development and preparedness as a whole. With this, we fulfill not only one of the aptitudes of the World Health Organization's five-star doctor, but all of the five, from being a care provider to being a community leader. Reassess, reevaluate, reimagine, and then act. We must look at the bigger picture and make sure that there will be no student left behind. Let us invest in the future of our field. Maraming salamat po.
Thank you very much. Naiko, it's Naiko, right? Naiko?
Yes, Nico Bautista. Yes.
Yes po.
Thank you very much for that. Okay, we're going to call everyone into the discussion. So, Executive Director, former Chancellor Arcadio, if you're still there, we'll have Dr. Roderico Ofrin from WHO India, and our guest speakers from the different colleges of medicine, Dean Charlotte Chiong, Dean Shin Chan-Su, and I'm not sure if Dr. Rajiv is still here, Dr. Rajiv Kumar, and of course our students. So let's have everyone on the screen. And we do have a little time to have a bit of discussion. And I think, we are of course encouraging our audience to participate and to ask questions, and for the panel to interact. So I think I'm going to start with a question for everyone. And the situations are similar in the three countries, in the Philippines, in India, and in Seoul. I think the question ahead of us is, how do you how do you make how do you create a doctor in a situation where our previous methods can no longer be applied? The old tradition, the profession of medicine is very traditional. It's grounded in tradition, and now we need to break away from tradition and do new things. So I think question is, this requires leadership among the faculty, and we have heard some of our youth leaders here. So maybe the first question I have for the deans is, how do we strengthen leadership during the pandemic? We don't have the luxury of doing it before the pandemic happened, but now we need to have doctors, teachers who have grit, who are resilient, and who are nimble and flexible and can look for opportunities to enhance learning. So how do we address leadership? So we'll start with any of the deans. Maybe Charlotte.
Thank you, Susie. I think that's a very pertinent question, and it's always a sort of very challenging, especially in crisis, when one has to make really big decisions, taking the cudgels for the whole institution. I remember when the APMC declared that everything should stop. I was actually on leave. Actually, I was in Batanes at that time for my annual leave, and so I was trying to monitor, and of course, Dr. Legaspi called me, and we talked to each other. Paano na, Sir Charlotte? Interns are being called out, and rotations are being stopped. So I just told GAP, well, we cannot do anything about it, but we have to trust the way we actually taught our students. If that value of being of service to the country will be there, then we just have to trust that some of them will elect to still serve. And that's exactly what happened. But we do know the safety issues, and we don't want to. And between GAP and I, we were talking about, well, GAP, we have to make sure that our healthcare workers are safe. We have to follow WHO protocols. If we're going to have a COVID ward, make sure that exposure will only be limited to 4 hours, if not 8 hours. But we need to have to give them shifts, and we need to be able to quarantine them. So those arrangements had to be done very quickly, and we had to be very agile in our decisions. But the good thing is that I think because the community trusted us in making the decisions that we thought was the best, they followed. The worst thing that can happen is you have fragmented decisions, and the people that you're supposed to lead will not follow. And we're just so lucky that as true to tradition of UPCM and PGH, that DNA of service took precedence over anything else. And as leaders, we just had to make sure that we protect the workers who are now putting themselves in line, in the front lines. If you remember at that time, we had our colleagues who actually were dying. In fact, the main impetus for this is that my own anesthesiologist, whom I've been working since I started my practice, actually died on March 22. And we actually did surgery on March 8th. So I was actually, when I heard that he was hospitalized for COVID, I had to quarantine myself. And when he died, and then all of a sudden our cardiologists, our mentors, and senior professors were dying, we were looking at a big picture of how do we protect our frontliners? How do we protect our faculty? So GAP was audacious enough to tell me, Charlotte, we will do everything that we can. I can tell you, if anybody died in this hospital, I'm going to resign. And he actually verbalized that. And it's just so lucky that nobody died from exposure in the hospital. Although even he himself was infected, and even the spokesperson of PGH was infected, and all the others were infected. So we're now at a point where leadership has to still be very important. And I think that as we move to the next normal, we need to be able to exert this. And now, as I think with our partnerships, I think leadership in medical education and among our faculty will need to be able to develop the next generation of leaders. I mean, it's good that we learn from people like Dr. Arcadio, from former chancellors and former presidents of the university about the courage in leadership, the need for courage and grit, as you said, and agile response to pandemics like this.
Thank you, Dean Chong. How about Dr. Shin? Your thoughts on developing leadership abilities of the current crop of medical students?
I think as a leadership or dean, in charge of medical school, the safety and well-being of the students and also faculty is crucial. In the era of telemedicine, video-based learning, the safety issue depends on the self-directed management, self-directed care of himself, of the student or herself. So in the meantime, the guideline in our institution is to direct, to avoid any unnecessary meeting or dining with colleagues or friends, so that the unnecessary chance of infection can lead to next infection to colleagues or even to the patient or to the student. So to make a clear-cut guideline and communication with the members is utmost important. So that kind of direction can prevent any unnecessary spread of infection to the whole community. And during the clerkship in the hospital, I mean, third or fourth year medical students, I think the education of the students on the self-directed measure, I mean, self-protection as well as protection for the patient is very important and can be provided by the hospital leadership as well. So during the past 10 months, there have been only a few cases of COVID-19, confirmed cases among students and doctors, also in the patient of SNU. So I think this kind of proactive measures on self-directed measures is very important and should be continued to prevent this kind of community spread. And but my main concern is there may be more and more abrupt and more huge scale infection can come in the winter season. So that may overwhelm the ICU beds of the hospital or in the whole country. That's my comment.
Thank you very much, Dr. Shin. Is Dr. Kumar still with us? Okay, we're going to go to Dr. Roderico Ofrin. Roderick, what are your thoughts on developing leadership among medical students?
That's it's a very complicated question, but I think it begins with providing examples. We learned from our professors because they were examples to us. So that's one part of it. I mean, we see in them our future. So how they conduct their classes, how they treat their patients was always an example. So it's really, as mentors, as professors, it's really providing that example. Two, it's multidimensional. In this forum alone, you have students, you have deans, practitioners, etc., all together, kind of coming together to define this. And I think that's what's next. It's not just as Dean Chiong was saying, it's not just her leadership, but her leadership with the director of the Philippine General Hospital. It's probably leadership that you expect from suppliers of PPEs, masks, gloves. So it's and if you see, if listening to this forum, each university is a thought influencer, a thought leader in the country. So there is that part where it's not just what you do for the school or the university, but how you will influence other hospitals in terms of their practice, other medical schools in terms of managing students. That's key. At the end of the day, I think all of us are really looking at a leadership, but with basis of our understanding of the risks. That was the action for the health professionals, for how do you say, the interns, the students, knowing their risks, knowing the risks we face. So that's also a brand of or a a perspective of leadership on how you're managing an event that's evolving. But for the future, it is also looking at a preparedness. There is a bit of fear because we know that infection prevention control systems are probably not as tight, not as strict. The schools we've heard are well resourced, but maybe there are other medical schools that are not. So that's another part. It's like really looking, to me, the leadership is looking at the system, but becoming the examples for now, so that it can inspire the students of the future and the practitioners of the future.
Hey, thank you, Dr. Ofrin. Let's go to Dr. Arcadio. Your thoughts on leadership. I mean, the reason I'm asking this question is because we're in a constantly changing environment, and what we talk about now actually might change a few months from now, right? So, Dr. Arcadio, what are your thoughts on instilling leadership qualities of our students?
Well, we are in a situation where there is a problem of an infection. So the leadership will have to be advised by the infectious disease group. No? And in drawing up the safety rules and other guidelines, the dean should consult the faculty, the students, and also the hospital community. It cannot be coming only from one sector, one group, one office. It has to be a consultation of faculty, students, and hospital community. And then the important thing also is the public health education. The patients are there, the watchers, the bantais are there, and unless they understand what it is all about, then you will not succeed in implementing the rules on safety. So a public health education program must be very active.
Thank you very much, sir. Our students, Nico wants to say something. Nico, what are your thoughts on this?
Hi, Doc. I believe that great leaders are forged in crisis. And I believe that we are doing that now, like instilling leadership instilling leadership qualities for the future. It starts with a spark and or an initiative. And aside from training great care providers, we have to allow opportunities for our physicians or for our future physicians to take charge during these times. I mean, you guys, our mentors, are involving us as of the moment. And that really is one way of instilling that leadership quality in us. And as mentioned by Terence, there is a lot of untapped potential in the youth sector. Deviating from the traditional, as you mentioned earlier, the youth's ideas can lead us to a bigger change. And we just have to allow them and take ownership of these actions, but with the guidance of our seasoned mentors, such as Doc Arcadio. I mean, in our organization, Doc Arcadio has always been there with us, and he has been guiding us. And that is one way of instilling leadership qualities for us, the youth. In our organization in APMC, we have a surplus of ideas and initiatives, not only focused on medical education, but also in community engagement. And we are currently implementing them with the mentoring of Dr. Arcadio. So I think that is one thing. It's not totally a new thing for us, but then more of a continuing thing already. So it starts with an initiative from the youth, and then giving them opportunities or allowing them to take charge and flourish on their own. But then, of course, with the guidance of our mentors, something like that.
Yeah, thank you. I mean, so I think we're coming to some general points of agreement, right? That the faculty, the doctors today, the seniors have to lead, but we're also saying they have to be examples. They have to be engaging with the students in a very different way and mentoring. And we have to be looking at the initiative of young people also, because they can think of solutions also by themselves. Terence, did you want to say something?
I no, Doc, but I totally agree with Doc Naiko that the potential of the student organization, especially when collective, really says a lot in forming the power of the youth in the future as both as individuals and both as doctors.
Right. How about Jay? Jay. It's Jay, right? Your nickname is Jay?
Yeah, G
G.
Hyun Kim.
G.
Yes.
Okay, go. G, what
Oh,
do you
well,
think?
I agree totally with the two other students, and also, I think it's a um the characteristic, unique characteristic of medical students, as I've said, is that particular class stays as a one group and goes on actually for forever, and at such time of this crisis, I think it's a very kind of we could say it's a crisis, but it's actually another great opportunity to actually be together and like find ways to actually stay in contact together. Yep.
Yeah, I think that kind of summarizes it. It's like it takes a village to make a doctor, right? It takes a community. This is not just technical training, it's not just learning remotely, but it's being a community that's, what should I say, bonded. That's really working together as a team. Raymond, did we have any questions from the audience? I'm mindful of the time and that our guests are very busy, but maybe we have one or two questions from our audience.
Right. We have three excellent questions. I'd like to get into the top most voted before choosing, or maybe we could do all three. The top most voted question, it's a tie, but we'll start with the first question with regards to regarding internships, not just for medicine but also for the other healthcare professions, nursing, for the pharmacists, for let's say for the dentists. How do each of the different universities how are they preparing for their reintegration into the hospital? In particular, because obviously a lot of the innovative strategies and learning techniques have been mostly focused on a combination of asynchronous and synchronous modules. But there is a sense also that we should not really overlook the importance of the practical, the laboratory part of it, the, let's say, the clinical experience for the medical students. So how do each of the universities see that changing, or maybe moving forward, how all of these will be accommodated? Let's start with Dean Shin from Seoul National University.
인턴십을 그러니까 지금 상황에서 어떻게 그 이전과 비교해서 달라진 점 뭐 이런 거 있어요?
Okay, that's the point. Your point is the internship training in the hospital.
Yes, that's correct.
Yeah,
What's the plan?
Really,
What is the plan?
yeah, different from other countries and other institutions, because the interns and residency training belongs to the hospital side, and the dean doesn't care about the intern or residency training. But in Korea, we have, I mean, relatively few cases in COVID-19. So at the moment, internship and residency training is not different from that used to be in the last year or before. So as interns and residents, they are frontline medical personnel, not a student. So they are actively involved in patient care regardless of this current situation. And that should be, I think, continued in the future as well, as long as they have provided with enough personal protective equipment and education on their self-protection system. Yeah, that's my answer.
Yeah, thank you.
Dean Charlotte?
Yes, there are two aspects to that question. One is the internship in the hospital, and the second one is for interprofessional education and how we plan to get them back. So for the first question, as I mentioned, with the controlled community transmission of COVID and showing the decline of the number of cases and showing the number of COVID admissions going down at PGH, and the increase in the number of cases, like I know that out of 2,100 pre-COVID in terms of consultations per day, we are now at the level of around 600 consultations, either face-to-face or teleconsults. So there's a rich opportunity for our interns, whether there are the students, the LU7 students, about 160 of them, and postgraduate interns that have elected to do their internship at PGH, for them to go back and have this experiential learning. On the premise that we assure that the hospital is safe, that protocols are in place, and as long as they commit to following the protocols, then we should not be worried. But that if there's any infection, they have full coverage under the Bayanihan Act law and the PhilHealth memo that says that all healthcare workers and frontliners, and they will be considered as such, will be given full coverage in case they get sick. The second is the interprofessional education. As you know, UP Manila has a comprehensive community health development program, which is based in Amiga, the provinces in Cavite. And we actually went to APMC to ask their permission whether we can already start community rotation. And this is where pharmacists and nurses and other allied medical professions come together with our interns to be able to manage the healthcare, the community. Actually, on a survey of the community, they're actually excited to have them back. They are not very keen on online consultations in Cavite as per our survey, but they would like to welcome them back. And so we are actually looking at whether the transmission of COVID will die down in this province, in the province of Cavite, such that we probably will go back to APMC to get their permission to start community rotation. But as of now, the plan is for them to go back, and perhaps for the whole of UP Manila, including the allied medical professions, to have them back perhaps by January.
Okay, thank you very much, Dean Charlotte Chong. Raymond, I think our guests need to go. So we're going to wrap up, and we're going to ask for parting words and some last thoughts that you want to share with the audience. We're going to start with Dr. Roderico Ofrin, WHO India. Roderick, go ahead.
Thank you. I think I will just end with the last 3 R's that I have mentioned. It is really to reimagine education without boundaries, to realign, to change the context we work in, and of course to reset with humility. This is if we have these principles around in terms of how we will even train leaders of the future, even addressing the next steps, whether students will come back. I think it's something that will help every country prepare better for the next big outbreak, next pandemic, next emergency, and not only a country but the world, because it started from one place, as I've said. So thank you for the opportunity.
Thank you very much, Dr. Ofrin. Dr. Shin, what are your parting words for us?
Okay, I think from today's symposium, I realized that we have very similar perspectives and similar situations all around the world. And many of us will remember this COVID-19 as a disruption, but I think it's maybe a catalyst for transformation as well. So I think we need to begin to plan to sustain this transformation as medical education becomes refreshed. Yeah, that's my thought.
Thank you very much. Dr. Ramon Arcadio, sir, please go ahead. Give us your parting words. Sir,
Dean,
are
I
you
think
there?
you're still on mute, Dr. Arcadio.
We have to give the hospitals the freedom and authority to modify the instructional design for interns and the requirements for as long as they meet the approved learning outcomes. Then the strategies may vary according to the hospital's design. No? Then we have to address the fear of the interns in going back to the hospital. We have to address their fears and their concerns of the parents. No? And in the drawing up of the safety protocols, we have to involve them in drawing this up. And as far as the interprofessional education, it's very important that a community rotation be instituted right away, but we have to discuss the safety measures before we allow these students to go back to the community.
Thank you very much, sir. Let's go to G. What are your last thoughts, parting words?
I guess. Oh, wait.
Go ahead.
Oh,
Go ahead.
okay.
We can hear
Yeah.
you. We can see you.
Mm-hmm. Yes. I agree with Dean Shin that we are students right now, but after we graduate and become an intern, we actually become doctors, and I think the COVID-19 is actually a crisis, as I've said before, but will actually with straight guidelines and preparations, I believe that we would become even more competent doctors in the end after getting all the experience and also fighting against the COVID-19. And I think all of the panels and all the professors and for sharing a very good experience, a very wonderful experience and knowledge. Thank you very much.
Thank you very much. Terence,
Hello, can you
go
hear me
ahead.
po?
Yes, go
Yeah.
ahead.
It's actually very good that we have these kinds of discussions, both from the academe, through our respected deans, and us student reactors. It made me realize that really everyone is doing their part. A lot is still uncertain, but it's never wrong to be hopeful that in the coming months we could move forward and have a better medical education in our new normal. That's all.
Thank you very much. Naiko,
Ayan. First thing, I would like to thank all the organizers and our speakers for the opportunity to be with you guys. I mean, I really feel honored that I am in line with you guys. And my last words would be for us to join together and start reassessing, reevaluating, and just like what Dr. Orphin said, reimagining what the future would be. And we should start acting because just like what I said earlier, we already have these patterns. This is not the very first pandemic that happened. This is not the very first natural calamity that struck our nation, and we could have prepared for this. So in the near future, I hope that everybody who's listening, the people who are organizing this, we can start acting and not just merely talking about it. That's all.
thank you
Thank you.
very, very much, Naiko. Before we call on Dean Charlotte Chong, who's going to do the closing remarks, and she would also give her parting words, I think we have an evaluation poll. Raymond, do we want to launch that? So we have a quick
Okay, so
evaluation poll for the
yes,
audience.
yes. Thank you so much for the parting words from all of our speakers and also for Dr. Susie. This assessment really is all about the level of knowledge that was gained by all of our attendees, or at least the attendees who inputted into this poll. I'll just read off the list, and then we hope that our 171 attendees who are still in this call will be able to key in their answers. Number one will be demonstration of thorough knowledge of the topic, the well-preparedness and organization of our speakers. They spoke clearly and audibly, and they used appropriate language with technical medical jargons adequately explained. And then finally, most importantly, did the panelists contribute to new perspectives and knowledge of managing various key COVID-19 health issues? So please key in your answers. And as always, we see a strong agreement from nearly 90% of our attendees for all of the knowledge and all of the experiences and the learnings that was shared by our panelists and speakers for today. Dr. Susie.
Thank you very much, Raymond. So, Dean Charlotte Chong of the UP College of Medicine, you're doing our closing and your final thoughts on our discussion today. Go ahead, Charlotte.
Thanks, Susie. First, I'd like to summarize what we have discussed. I think Dr. Ofrin, who's actually an alumni of the UP College of Medicine Class 95, thank you for, and nice to meet you here, presented actually that this COVID crisis really is an opportunity for resetting and realignment among both the academe, the policymakers in government, the clinical practitioners, and even the researchers. That these pandemics really underscore the need for different sectors to actually come together and collaborate and cooperate with each other in order that we can accomplish what we really are all set to do from the very beginning. It's really because we need to serve the people. This experience is actually shared by our international friends, Dean Shin Soo and Dean Kumar from India and from Korea. And these institutions show common priorities, ensuring patient safety, agile readjustment, perhaps hospital setups that can adapt to patient needs and safety of healthcare workers, and that clinical training, while it may subsume to delivery of service, still need to clearly focus their efforts on trying to prepare for the future, and science-based solutions based on evidence like research that can have an immediate impact to society had to be prioritized. So when the battle comes in with an invisible enemy like this virus, what we really earnestly hope is that our motivation now and our eagerness to work together and share experiences, the drive that we have right now to fight this enemy will translate to equally important issues. For example, being able to prepare for the next pandemic and even focusing on equity, taking out the barriers to access to healthcare so that financial need not be an impediment to accessing quality healthcare. And similar to what Dean Shin Chan Su said, this time is an opportunity for us to look into the medical curriculum, which we did, not only in terms of being able to deliver the courses, but also in terms of being able to respond to the needs of our students, as well as looking at learning outcomes and content that will actually address the needs of society now and in the future. And as mentioned by the student, they have to be involved. And we have been doing this at the UP College of Medicine. They're in our, we have the Medical Student Council. They are part of the College Council. They can listen into all the discussions of faculty. They're actually involved in all programs. We do constant surveys. We have town hall meetings to talk to them if they have issues. So we have to be flexible in being able to deliver this medical course to them that actually answers their needs. So we got some good suggestions from this webinar that we have to be able to include in our training, triaging, as well as emergency care for our medical students. And although we're offering it at LU5, LU6 for our students, I'm now thinking of maybe we should actually offer it at an earlier stage, perhaps in LU3 and LU4, so that they know already to contextualize the medical learning is really based on how they can actually save lives. So from this webinar, what I would like to say is that it has been a very difficult time for leaders like us, Director Legaspi and me, but we follow the examples of our mentors. And the trust that has been given to us by the community, the UPCM community and the PGS community, has been very inspiring to us. And we hope that this translates to better care, empathy for our students, making sure that we take care of them, their mental health, answering their needs. We did that. We look for donors, and our community of alumni have been here to help us, even if they're abroad. They've been helping us, giving whatever was needed. Right now, I think we've already raised more than 1.5 billion for the Pantawid Scholarship Program, so that we are able to actually aid the 47 regionalization program students in the remotest barrios of the country. And we are now, I'm very pleased to tell you that although the internship is supposed to start by January because of the protocols that we followed, I got word today that more than 200 interns out of 300 plus interns have now decided that they will come back this November instead of January. And so we will be able to see how we may be able to get the clerks back by January, because as has been experienced in other countries, if you get them all together at one time, it might even be more difficult. So having a cohort of students come back at an earlier stage will probably be very beneficial. And this will allow us to calibrate again and recalibrate whether it's safe for our clinical clerks to come back by next semester. So this webinar has been a very good learning experience for me myself. And I'd like to thank the organizers of this webinar, TVUP, the Office of the Executive Vice President, Ted Herbosa, of course, you, Susie Pineda Mercado, and of course, Raymond Sarmiento. When we talked about this virtual grand rounds, and I was very excited by the videos of scenes of patients, and I think that's a good jump start for medical students to see and contextualize the learning. And we're going to curate all of this and make sure that we put them in chunks of learning materials for our students in the future. And these virtual grand rounds, as it moves forward, I think will be even more beneficial to all who care to listen, all who care to learn more, and our students will benefit from this. And I'd like to thank you all for this opportunity to address this webinar and share my experiences, as well as to give and promote the vision of the college. This is leadership in community-oriented medical education. Universal healthcare is not lost on us. Primary healthcare, we will develop tracks in pediatrics and adult medicine. We have dual tracks for the MD PhD program, and we're now working on the MD MPH program and the MD Clinical Epidemiology program, new degree programs that will allow our students to choose the path by which they want to engage as doctors for the future. Because we think that you should be able to have that passion, and we are here to help you accomplish that. Thank you very much.
Thank you very much. That was Dean Charlotte Chiong of the UP College of Medicine. And on that note, we bring this webinar to a close. Next week, we're going back to the Grand Rounds format. We've got a very interesting case. We have a pregnant woman who got COVID. And this is a patient that's co-managed by the Philippine Lung Center and the Philippine General Hospital. So for the first time, we're going to hear of a case with presentations from both hospitals. So this patient had COVID, was seen at the Lung Center, and then because it was a complicated delivery, was brought to the Philippine General Hospital, but she developed sepsis and was brought back to the Philippine Lung Center. And we're going to hear how they saved the life of this patient. So be with us next Friday when we return for our Stop COVID Deaths webinar under the University of the Philippines and the Philippine Health Insurance Corporation. Raymond, over to you.
Thank you, Dr. Susie, and thank you for that inspiring closing remarks from our Dean from the UP College of Medicine, Dean Charlotte Chiong. As mentioned by Dr. Susie, we will be reverting to the virtual grand rounds format starting next week, which will be our 32nd episode. So we are nearing the end of the year, and hopefully we end the year with a bang and start the year with a bang also for 2021. And for the benefit of all who are in this webinar, I'd just like to say that we are being viewed all over the Philippines, from Nueva Vizcaya, from Oriental Mindoro. We also have ones who are viewing us from Visayas, from Malay Aklan, and from Talibon, Bohol, and finally from Mindanao, from Zamboanga del Sur in the Zamboanga Peninsula. We are also being viewed internationally by the Camelot Adult Day Healthcare Center in Himet, California, from Balay Kesehatan Penerbangan in Jakarta, Indonesia, and our regular viewer from Niagara Falls, Ontario, Canada. This has been really an exciting and very, very fantastic discussion on the innovation and transformation of medical education as a result of the pandemic. Please continue to join us in our next few webinars as we close the year. I'm Dr. Raymond Francis Sarmiento. Keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others lives before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others lives before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will hold